Welcome to A Sound Constitution here on CHLY 101.7 FM, a show where we focus on health topics important to our community. This year's team is made up of 5 third-year Vancouver Island University Bachelor of Science in Nursing students. Our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available in our show notes on our Facebook and Instagram pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what's being discussed, feel free to reach out to us on Facebook at A Sound Constitution, Instagram at CHLY A Sound Constitution, all one word, or email us at asoundconstitution@gmail.com. We would like to start our show by acknowledging that we are on the unceded territory of the Snuneymuxw people, with a broadcasting range that overlaps the Quw'utsun and Slayamon territories. This acknowledgement is done with gratitude to the Snuneymuxw people and with the intention to increase awareness about truth and reconciliation processes and efforts on Vancouver Island. Additional information and resources surrounding Snuneymuxw history, reconciliation, protocol, and land acknowledgement can be found on our Facebook, Instagram, and YouTube pages. I'm your host, Cameron, and today our episode is focusing on female sexual and reproductive health and the United Nations Sustainable Development Goal 5, gender equality. I am joined today by my co-hosts, Dana, Taylor, Amanda, and Haben. We have a jam-packed episode full of women's reproductive health information. We'll be discussing HPV and Pap tests, bra health, some fun facts, and we were lucky enough to sit down with Dr. Tracy Rodgers, an obstetrician and gynecologist in Courtenay, BC. She's going to talk to us about menopause and women's health. I hope you enjoy this episode as much as I did. To kick off this episode, I'm going to speak a little bit about gender equality. In 2015, the United Nations created an outline for peace and prosperity for people and the planet now and into the future. This outline references 17 goals that align all countries to form a partnership to better the future for everyone, everywhere. Throughout this season, we have been discussing many of the Sustainable Development Goals, and today we will be discussing Sustainable Development Goal 5. SDG 5 focuses on the empowerment of women and girls to achieve gender equality. Discrimination against women and girls is seen globally, whether it be through violence, unequal pay, decreased rights, or the inability to access education and health care. These examples all hinder the freedom and rights of women. SDG Target 5.6 indicates the need for equal access to sexual and reproductive health and rights. Throughout the world, organizations are working to increase accessibility to healthcare, resources, and education. In our community, Vancouver Island University is actively working towards reaching gender equality. To increase access to sexual and reproductive health, VIU has a health and wellness center that provides services and information so that women, and all students, no matter their gender, are able to make informed decisions about their health. The VIU Wellness Center provides resources within the community to further access healthcare, provide services such as Pap tests, STI checks, and contraceptive prescriptions. Now, although this episode focuses on reproductive and sexual health promotion for women and girls, the fight for gender equality requires action from all genders, all people, everywhere. To provide more information about SDG 5, let's listen to an audio clip entitled The Facts About Gender Equality and the Sustainable Development Goals, created by UN Women, a United Nations entity working for gender equality and the empowerment of women.
The 2030 Agenda for Sustainable Development promises to make human rights real for everyone, everywhere. It has 17 goals and gender equality cuts across all of them. At a time when we're facing conflict, extremism, and environmental degradation, the SDGs focus on sustainability, equality, peace, and progress. The SDGs challenge deepening inequalities around the world by committing to leave no one behind.
The 2030 Agenda is very clear. There can be no sustainable development without gender equality.
In reality, however, gender inequalities are pervasive in every dimension of sustainable development.
Globally, women and girls are overrepresented among the extreme poor. 330 million women and girls live on less than $1.90 a day. That's 4.4 million more than men.
In nearly 2/3 of countries, women are more likely than men to report food insecurity.
Despite recent progress, access to quality education is still not universal. Globally, 15 million girls will never get a chance to read or write, compared to 10 million boys.
Climate change has a disproportionate impact on women and children. They are 14 times as likely as men to die during a disaster.
The majority of urban women are living in conditions where they lack access to clean water, improved sanitation facilities, durable housing, or sufficient living space.
In many areas, the current rate of progress is too slow to achieve the SDGs by 2030. To turn promises into action, we need to step it up now.
We need public action to tackle inequalities and discrimination.
We need to invest in policies and programs that work for women and girls.
We need more and better data to assess whether what we are doing for women and girls actually works.
And we need greater accountability at all levels for commitments made but not met.
Let's turn these promises into action.
And gender equality into a lived reality for all women and girls.
It's up to all of us
to ensure the journey is successful.
Welcome back to A Sound Constitution on CHLY 101.7 FM. My name is Cameron and I am your host for today's episode. You just listened to an audio clip about Sustainable Development Goal 5 by UN Women. If you would like to listen to that clip again or learn more about UN Women, you can find these links and resources in our show notes. Now that we know about Sustainable Development Goal 5, let's talk about some important aspects of women's sexual and reproductive health. First up is HPV. Here's an audio clip entitled, "What is HPV and what is the HPV vaccine?" This video is created by Cancer Council Victoria, a nonprofit cancer charity organization involved in cancer research, patient support, cancer prevention, and advocacy.
Well, HPV stands for human papillomavirus. This is a virus that is very commonly found in young people, transmitted through genital skin-to-skin contact or through sexual contact. There are many different types of HPV and they can infect various different areas of the body. But in fact, there are about 50 types that almost exclusively just infect the genital area. And of these 50 types, about 15 are so-called oncogenic types. That means they have the potential to cause various different anogenital and in particular cervical cancers. Now, most of this infection is completely silent. In other words, when people are infected with this virus, they don't actually know that they've got it. Some types can cause genital warts. Genital warts are benign lesions, they don't cause cancer at all, but they can be very distressing. HPV is a very common sexually acquired infection, and you find that within the first few years of commencing sexual activity, most people are infected with at least one, if not more, types of HPV. In fact, it's so common that we often refer to it as the common cold of sexual activity. Once young people start becoming sexually active, they very quickly acquire one or more of these HPV types. Now, in the vast majority of cases, our body deals with this virus and we clear the virus from our system. Our body, our immune system learns how to cope with this virus. But very occasionally, with some of these 15 oncogenic, so-called high-risk HPV types, for some reason we don't clear the virus and the body becomes the virus becomes integrated into the cell and becomes persistent. So it's very exciting when we think about what this new vaccine can do and how it can help to prevent cancer.
You just listened to an audio clip about HPV by Cancer Council Victoria. Now, I would like to welcome my co-host, Taylor, to further discuss HPV and testing.
Thank you, Cameron. Yeah, I just wanted to share a bit of information on this topic because I recently received a pamphlet in the mail from BC Cancer about a cervix screening pilot they are doing in central Vancouver Island and the Sunshine Coast. From what I understand, I received information on it because of my age. It looks like they are picking possible participants based on their ages ending in 0 or 5. Basically, they are trying to assess how best to offer at-home cervical screening kits and see what the response rate is of this pilot. For this pilot, it is just focused on screening for human papillomavirus, also known as HPV, which is different from the Pap test, also known as Pap smear, which looks for abnormal cell changes that can be caused by HPV. So I just wanted to take a moment to provide some information on HPV screening, and Pap tests. So HPV is a group of more than 100 types of viruses. It is the most common sexually transmitted infection, or STI, and it spreads through any kind of sexual contact. According to the Canadian Cancer Society, HPV is more common than all of the other STIs combined, and approximately 75% of sexually active Canadians who have not received a vaccine for it will have an infection at some point in their lives. It is spread through any kind of sexual contact but cannot be spread through casual contact such as shaking hands, hugging, coughing, or sneezing, and it isn't spread through food or water. An HPV infection is usually cleared by the body's immune system within 2 years without causing any issues. However, out of the more than 100 types of these viruses, approximately 15 of them can lead to cancer. According to BC Cancer, it's estimated that 99.7% of cervical cancers are associated with a long-term HPV infection. So there are two groups of HPV, low risk and high risk. Long-term infection, typically 10 years or more, with a high-risk type of HPV can cause cells of the cervix to become abnormal, and if not found and treated, this is what can lead to cervical cancer. This is why it is so important to have regular Pap tests done to identify these abnormal cells, or having HPV testing done, as it usually takes 10 to 15 years from initial infection with HPV to the development of cervical cancer. To reduce the risk of infection with HPV, there are vaccinations available that prevent against the most common types of cancer-causing HPV. These are offered in most school vaccination programs. Additionally, during sexual activity, anything that provides a barrier and prevents skin-to-skin contact, such as condoms or oral dams, can reduce but not completely eliminate the risk. The HPV test and the Pap test are two different cervical cancer screening tests. The HPV test is the one I mentioned earlier when I was talking about the BC Cancer cervical screening pilot. It tests for the presence of HPV, which, as mentioned before, is the virus that can cause abnormal cellular changes that can lead to cervical cancer. A Pap test, which I learned is actually short for Papa Nicolau test, but you rarely hear it called that, is done by your healthcare provider, and it involves collecting cells from the cervix, which are then looked at for any abnormal changes that may indicate a higher risk for the development of cervical cancer. A positive HPV test does not mean that you have cervical cancer, but it does mean that you have a type of HPV that is associated with precancerous changes in the cervix. And a follow-up with your healthcare provider for additional testing, such as a Pap test, is recommended. BC Cancer recommends that anyone with a cervix between the ages of 25 to 69 should screen regularly. This includes people that have had the HPV vaccine, have ever been sexually active, even if you aren't currently, been through menopause, or are in same-sex relationships. In British Columbia, it's recommended that Pap tests are done every 3 years and HPV testing done every 5 years, starting at the age of 25. However, HPV testing isn't routinely used in provincial cervical cancer screening programs because of how common HPV is and the ability of your immune system to clear it up on its own without treatment, so Pap tests are more routinely used. As discussed, a Pap test can identify abnormal cervical cells that require treatment to prevent the development of cervical cancer. If cancer does develop, routine screening can find it at an early stage, which allows for the availability of more treatment options. According to BC Cancer, if cervical cancer is caught at its earliest stage, the chance of survival is 85%. Fortunately, with routine screenings available, this makes cervical cancer very preventable, so I encourage those eligible to have routine screenings done, as it can be very beneficial for your health. I really hope that you have found this information helpful and that you have a better understanding of HPV and what you can do to prevent cervical cancer. I also wanted to say that I was quite thrilled to hear about the screening pilot that BC Cancer is conducting, because I think that this is a great way to promote accessibility to healthcare services, and it will help those who do face barriers when accessing healthcare. So I'm looking forward to seeing what becomes of this.
Thank you, Taylor, for the great information about Pap tests and the new cervix screening pilot program. I would also like to remind our listeners that this episode is being recorded in March of 2022, and recommendations for testing may change. Speak with your primary healthcare provider for more information about HPV and when you should be receiving Pap tests.
Did you know sexually transmitted infections, also called STIs, are seeing a rise year after year? Prevention and education about STIs and sexual health is important for everyone, not just adolescents. As per Health Canada, while those under 30 make up the bulk of STI cases, older adults are seeing the highest increase in cases. Between 2009 and 2018, people 60 years of age or older had the largest relative increase rate of chlamydia at 134%. They are also seeing increased rates of syphilis, gonorrhea, and HIV.
Did you know the life expectancy of female babies born in 1921 was 61 years old, while female babies born today are expected to live to age 82?
Next up, my co-host Dana sits down with special guest Dr. Tracy Rodgers to talk about menopause, hormones, and women's health.
So Tracy, thank you so much for interviewing with us today, and we're just going to get right into it. So my first question I have, because I'm always very interested in this, is what led you to decide to work in gynecology and obstetrics as a specialty?
Well, that's a funny story, actually, and one I told at a talk I recently did. I didn't know what I was getting into when I went to medical school, like not a clue. So I sort of thought maybe I wanted to do pediatrics. But anybody who knew me when I was a kid, all I ever talked about was being a teacher, being an educator. But I went to medical school and I realized very quickly I didn't actually like pediatrics at all. Like working with sick kids and their families was not my forte. I couldn't do it. And when obstetrics was one of my earlier rotations. And I remember one night on call, we had this sort of crazy delivery and you're seeing everything for the very first time. And I remember elbowing my friend that was in my class with me and saying, okay, I'm definitely not doing this because crazy people do this. And here I am, because part of it is women's health is such a rich specialty. Like we think of it as, C-sections and hysterectomies, but it's like you're caring for women through every aspect of life. There's so much endocrinology, medicine, procedures, surgery, ethical stuff, emotional stuff. Like it's just a specialty that has a little bit of everything. And I also realized that my comfort level was with women as patients very early on. And so it just seemed like a natural fit for me. So this is my 20th year in practice, and I have never regretted the decision to do obstetrics and gynecology. I might have at a few points in my residency thought, what the heck am I doing? Because it was the hardest 5 years of my life. But it's been a very full and rewarding career. And like when I look at what I did earlier in my career and how it's morphed and changed over the course of my life, very few areas in medicine give you that same sort of broad perspective that women's health does. And I absolutely love it. So I got here by default, but I ended up being exactly where I'm meant to be.
My second question for you. So the Women's Clinic in Courtenay has been an essential part of the community there since 2008. Could you tell us a bit about the clinic and the services it provides?
Yeah, for sure. So I joined the community in 2008 and I've been here since, but I opened my own office in 2014. I sort of had a grand vision of doing this whole multidisciplinary clinic with lots of different services for women. And I realized very quickly that I couldn't do that off the side of my desk while doing my job and being a mom. But what we did do is we recognized one of the needs in the community was access to gynecologic care in terms of IUD insertion, Pap smears. There's a lot of women in our community who do not have a primary care provider. And there's a lot of women who don't necessarily want their primary care provider to do intimate exams. So some women have a male GP, they're comfortable with everything else, but when it comes to intimate exams, they prefer a female provider. So we, since 2014, have offered a self-referral clinic for women who just need a Pap smear and want to see a woman or need an IUD inserted. And I've provided support to the female family doctors who've done this clinic with helping them learn IUD insertions, troubleshooting the difficult ones, that sort of thing. So women can actually self-refer to that clinic or they can be referred to the GP clinic. And that's been very active in the community. All the walk-in clinics are aware of it. And we get a lot of support from a lot of doctors in the community, because for a lot of GP practices, it's actually a relief to have somewhere where you can just tick a box on a referral and say, can you see for an IUD insertion? It's not a service we provide. Or there's actually a lot of family doctors, male family doctors, who don't like doing pap smears and female exams. So having a safe place to send their patients to where they know they're getting quality care is really helpful. And so that's kind of been a big part of my clinic since the beginning. And we've also had a perinatal loss support group that has ran out of this office, which was a huge need in our community. Unfortunately, that hasn't been running through COVID, but hopefully that's going to come back very soon. And that's been a tremendous support for the women in our community as well. And little things like there's a dietitian who sometimes sees people in my clinic. We're looking at starting to do some group work, those sorts of things. So trying to fill niches in the community where there are gaps in care, where women can access care, is kind of been my focus. The clinic is going to morph and change over the next few months. I want to do more gender affirming medicine. I may change the name of the clinic. The women's clinic may relocate, but that's all in flux, but it's a guaranteed thing that it's staying in the community. It's been successful for a number of years. And there's actually more doctors interested in providing that care, and the wait list kind of demands it. So it's been good.
I totally believe it. It is a very well-known approach that you chose, a very collaborative approach, and a very accessible approach for women in healthcare, as you said, with so many women not having access to general practitioners. So recently, you've been hosting a couple events regarding menopause, and you had one recently called the Menopause Monologues back on February 5th. Historically, there's been a very heavy stigma around women in menopause. So I read a stat that said that women spend 40% of their lives after menopause. Yet I also noticed that menopause is completely absent from the public discussion, unless it's like that stereotypical trope in medicine. And from the women I've talked to in my life, they didn't even really know what to talk to their doctors about, or if they did talk to their doctors, it was, well, that's just normal. That's just the way it is. Yeah. So
there, dear.
Can you talk to us about kind of like your advocacy and your work in having this menopause discussion, what led you to have it, and what you want women to know about all of this?
Okay. Well, you may have stopped me here, because I could talk about this for at least 4 hours without a break. But, here's the bottom line. Let's take a biologic approach to this for a minute. 100% of women who live to their mid-50s will go through menopause. This isn't something that happens to some of us. It happens to every single one of us. So we talk about something that 100% of women will go through, yet there's so little discussion and care and information and education about it. And when you ask people what comes to mind when they think of menopause, they think old, dry, wrinkly, my face is falling off my head, dry vagina jokes. And, women in their 40s are also crazy. So throw in a little smattering of that. And when you think about it, women go through menopause. There's a very clear biologic reason why this happens, because the cost of reproduction for women is astronomically higher than it is for men. And that cost increases as we age. So our fertility naturally declines as we age. It makes perfect sense when you think of it. And men just keep on keeping on with their fertility because there are no biologic costs. So historically, if women, their lifespan ended in their 40s, 50s, 60s, menopause wasn't such a huge issue. But as women are living healthy 4 decades past menopause, many of us, then the management of that transition and the prevention of chronic illness and all of the things that increase as we navigate menopause become extremely important. And so it has a biologic plausibility, and that's why it happens. But it isn't just like your periods stop and you get hot flashes for a while. Perimenopause lasts 5 to 8 years. So one of the big beefs that I have about menopause is people talk so much about the risks of hormones. That's an important discussion. I know that. However, how about we talk about the risks of not treating menopause, which is, lack of sleep, falling asleep at the wheel of your car. You're more likely to have an MBA, relationship breakdowns, loss of productivity at work, all kinds of fallout from untreated menopause. So there needs to be a lot more recognition about the quality of care that women need as they navigate this. But women need to be educated. There are so many women who don't even understand their menstrual cycle, let alone what happens when they start to go into progressive ovarian failure. Mental health symptoms show up very early in the transition. So you'll go to a care provider with all these symptoms. Are you having hot flashes? No. Your hormones are fine. Here's an antidepressant. And that happens over and over and over when a lot of those women would have had their mental health symptoms better addressed with hormone replacement therapy. I could talk about the controversy around HRT for a long time, but I'll give you the nuts and bolts version. For most healthy women, the benefits far, 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 far outweigh the risks. The risks are important to discuss, but the benefits far outweigh the risks for most women. And so what turned HRT on its head, as you know, was the Women's Health Initiative that was published in 2002. That was the year I graduated. So my whole clinic was full of sweaty women who had flushed their HRT and were terrified of breast cancer and had no idea what to do. And here I was, 31-year-old me, green as grass, taught a very cookie cutter approach to menopause that the Women's Health Initiative had just blown up. So the bottom line is the WHI was not designed to see if HRT causes breast cancer. It was designed to see if hormone replacement therapy reduced the risk of cardiovascular disease in older women. So the average age of women being prescribed hormones was 63. This is not where we're starting HRT, right? And so there were 3 groups, and it was Premarin and Provera, which is equine estrogens and a synthetic progestin, or a progestin, not progesterone, which is kind of older school hormone replacement therapy. It's not progesterone and ethinyl estradiol or transdermal estrogen, which we're using much, much more now. So can you extrapolate data from those hormones onto more bioidentical type hormones? Probably not. Can you take data from an older population and apply it to women in their 40s when they're getting the symptoms? Probably not. But the bottom line is there was placebo in each arm. One arm was estrogen only. The other arm was estrogen plus progestin. The study was stopped early because in the estrogen plus progestin group, there was an increased risk of breast cancer. Now, the media reported it as like a 42% increased risk of breast cancer on HRT, which women heard 42% chance of getting breast cancer. So it's important to understand risk. So one of the things I say to patients, if your risk of something is 1 in a million, and I make it 2 in a million, that's 100% increased risk, but it's still 2 in a million. So the actual increased risk was for every 10,000 women on hormones, there were 8 additional breast cancers per year. And the women on hormones, I believe, had earlier stage and better prognosis disease. They had a reduction in osteoporotic fracture. They had a reduction in colon cancer risk, but the breast cancer findings got a lot of attention. The estrogen-only arm was continued, and they were not shown to have an increased risk in breast cancer. So that study links an increased risk in breast cancer after several years in older women taking Provera, right? But the bigger thing that came out of that study was there was an increase in incidence of cardiovascular disease in the women taking estrogen. And the reason for that is there is a therapeutic window. So you know that old adage of suck it up, buttercup, and deal with your menopause for as long as you can, and only those that can't hack it should take hormones? Geez, that sounds like an epidural in labor, doesn't it? Funny how the themes overlap, hey? But that is no longer an appropriate way to approach it, because the benefits are with early initiation of hormone replacement therapy. Because if you go through menopause at age 45 and 10 years go by without estrogen, your vessels harden in that time. So vessel hardening, your risk of cardiovascular disease increases with the onset of menopause. Estrogen can delay and prevent some of that vessel hardening. So if you add estrogen 10 years later, then you're going to get vascular effects from the estrogen and precipitate cardiovascular events. So there is a therapeutic window. So women who are looking to treat their menopause with HRT, early initiation, and carrying it through the transition. Most women are off it before they're 60. But I also have women in their mid-70s who come in for their prescriptions and say, don't you dare take my hormones. And I say, wouldn't dream of it. Because Once again, there's not a lot of long-term data, and I believe women are capable of making risk-benefit assessments for themselves. And I don't get to say, you absolutely have to stop these hormones. When you come to see me in my clinic, you make the decision to get in your car and drive, which involves risk, probably more risk than your HRT, to be honest. And so we take risks every single day of our lives. You can have a patient that you say, you need this surgery, you need this chemotherapy, and they can say, thank you, no, thank you. No one straps them to a bed and forces them to have treatment. But we can withhold treatment with justifying it based on our perception of risk basis what the patient is willing to take as risk. And I don't really think that belongs as much in menopausal care. Fear of breast cancer, more women are afraid of breast cancer than they are of heart disease. Heart disease kills more women than AIDS, malaria, tuberculosis, and all reproductive cancers combined worldwide. It needs to be on our radar. All of the cardiovascular research has been done on men. Women's research is 40 years behind. We have to catch up. And HRT is an important piece of the puzzle in cardiovascular disease prevention. And for a lot of women, heart disease isn't even on their radar when they're having these discussions. So the Women's Health Initiative kind of ruined menopause as far as I'm concerned, but I value what came out of it in terms of the cardiovascular disease risk. And also there's a very big difference in clotting risk with oral estrogen compared to transdermal. So a lot of women are now using transdermal estrogen, which avoids the first pass through the liver, does not affect the clotting factors, doesn't increase your risk of thromboembolic disease in the same way that oral estrogen would. And, it's interesting if you say, when you take things that we apply to one area of medicine and apply them to something else, right? So like say, for example, you have a patient and you're worried about a clot and you tell them that hormone replacement therapy has an increased risk of clotting and therefore that risk is unacceptable. Has a doctor ever told a woman not to have a baby because of the risk of blood clots in the general population? I don't mean people who have a clotting disorder. No. Pregnancy is the highest time in your life when you are at risk of venous thromboembolic disease. And nobody says don't have a baby because of the risk of clots. And what I say to women is if you take hormones for 10 years and you get breast cancer later in life, you will never, ever, ever, ever know if that was going to happen, whether you took hormone replacement therapy or not. But maybe that 10 years of your life would have sucked a lot more if you didn't take it. And you could still be in the same boat you're in today. And we also don't talk about the fact that alcohol is a risk factor for breast cancer in women. We live in a culture where alcohol is heavily marketed to women in their 40s. Excess drinking, not exercising, and being overweight are risk factors for breast cancer and probably outweigh the risk of HRT. When you look at women on HRT, get a good night's sleep, they're more likely to exercise, they're more likely to take care of themselves. This is a complicated issue, and you can't just narrow it down to these risks, these benefits, plug in the value, here's your prescription. It's an individualized approach that has to discuss a tolerance of risk and what women's individual goals are as they navigate this process, right?
Did you know sexually transmitted infections, also called STIs, are seeing a rise year after year? Prevention and education about STIs and sexual health is important for everyone, not just adolescents. As per Health Canada, while those under 30 make up the bulk of STI cases, older adults are seeing the highest increase in cases. Between 2009 and 2018, people 60 years of age or older had the largest relative increase rate of chlamydia at 134%. They are also seeing increased rates of syphilis, gonorrhea, and HIV.
Did you know the life expectancy of female babies born in 1921 was 61 years old, while female babies born today are expected to live to age 82?
I really appreciate what you were saying that, and I was thinking about a lot of the women that I reached out to who are perimenopausal, going through menopause, or have finished going through menopause, and talking about the lack of individual treatment and individualism and treatment and patient-centered, and that we leave women to suffer because of this information, and trying to find that balance for women who maybe are afraid of doing HRT because of misinformation, or who do want to be on it but maybe aren't getting support through their healthcare provider, or lack of access, as we know is a continued issue. There isn't a one shoe fits all approach. Like, if we think about symptom management, and that was the big question, is like, how do I manage my hot flashes? How do I manage my heart palpitations? And they go online, and there is this plethora of information that is ranging from good quality advice to this is hocus pocus, please don't do this, you're gonna hurt yourself. And it's really hard to determine what is good quality information and what isn't. Do you have some recommendations or resources for women who want to try things at home to manage those hot flashes, to manage those palpitations, to manage that insomnia, that isn't maybe here's a prescription, like especially if they don't have access to a doctor?
Yeah, exactly. And it's extremely challenging to find good sources of information. It absolutely is, especially that are accessible to just about anybody who wants to read them. And so the Society of Obstetricians and Gynecologists of Canada have a website called menopauseandview.org that we do direct patients to. I haven't been on it in quite a while, so I'm not sure about the quality of it, but at least information being published by the SOGC is going to be medically sound information. How comprehensive it is, I'm not sure. The North American Menopause Society is a good resource for accurate information. And Dr. Jen Gunter, I don't know if you've heard of Jen Gunter, but she just wrote a book called The Menopause Manifesto. And in it, she does talk about hormones, but she talks a lot about, like, she categorizes a lot of the symptoms and talks about a lot of alternative and non-pharmaceutical options that women can use to treat it. I think there needs to be a buyer beware caveat in here, because since the Women's Health Initiative, the alternative industry has made billions of dollars on the backs of vulnerable women who are buying jars of stuff that called MenoSense to relieve their symptoms, and who knows what the heck is in it. There's no checks and balances. Somebody is making money off you for that, and that is not going to help you. So, women who are really determined to do their own research, my advice to them is find an article that says how to critically read medical information, so that you can get the basic Coles notes on how to filter the information. If somebody is trying to sell you something right away, move on. And follow the money trail. There are some supplements that are probably helpful, but you've got to pick your sources and your practitioner well. And I've seen women spend thousands of dollars on supplements, and then they come see me and get some bioidentical hormones, and they're like, well, that worked. And they've invested a lot of time and effort and money. So in that way, pharmacists are often really, really valuable sources of information. Like, go to a compounding pharmacy and talk to a pharmacist who's got an interest in compounding hormones about menopause and alternative therapy. Like, they know a lot of stuff, and they're going to give you stuff that's largely research-based. So there's a lot of avenues you can go to like that. There are some naturopaths who are very skilled at managing menopause, and there are others who would sell you hundreds and hundreds and hundreds of dollars of crap that's not going to help you. So again, you've got to choose carefully where you're getting and taking your information. But when you're vulnerable and you're dying inside with a lot of symptoms, it's really easy to reach for anything that sounds like relief. But there's not a lot of stuff that works like hormones. A lot of the stuff that's marketed to women doesn't actually work, and don't believe Gwyneth Paltrow.
Yes, I also agree with that. One last question I have for you. In what ways can people, like family members, so spouses, kids, friends, how can we support someone who is maybe going through perimenopause or menopause, and they're going through the difficulties of symptoms? Is there something that people can do, especially spouses? I'm thinking more along the lines of spouses.
Yeah.
Especially the majority of heteronormative relationships, a lot of men don't understand this. So how can they support their wives going through this?
I invite them to come to the appointment, especially pre-COVID, because if they can hear it firsthand, they get a bit of deeper understanding. And one of the things I've actually thought about is I should do a talk for men, for men who care about women, if you want to know what's happening. I think, share the things you're learning with your partner. But at the end of the day, you can't make people understand or, that sort of thing. So it's the same approach. It's educating people, but it's also learning to navigate the emotional stuff. Because in my experience, most couples, the reason men feel so exasperated with it is because of the mental health symptoms, the up, the down. You're good one week, you're not the next, you're touchy, you're irritable. Like, I wanted to murder my ex-husband for the way he chewed when I was hormonal. It is irrational. I tell my patients to explain it to your male partner and tell them that this is when they need to walk away, right? Like, it's navigating relationships. This isn't me, I'm hormonal. When I recognize these triggers, I need to tell you. So we, boundary setting and all of that stuff, but no one can help if they don't understand. So men need to be willing to read the literature. And like, if your partner reads an article about menopause and wants to share it with you, read it so that you understand. That's called empathy. And it's really hard for men to get it. It's really hard for them to get it. And we're not doing a good enough job of educating women, let alone men. And and then one of the biggest things in heterosexual relationships is discordant sex drive. How women just stop wanting to have sex and men don't get it. And I do a lot. I did a talk for Men's Health Month one year that was subtitled, "If you're 45 and over and you're not getting laid as much as you like, it's your fault, and here's why." I was being facetious, but a lot of men came and were really quite interested in hearing what happens with sexual aging with their partners and how men and women are different and how we can navigate those relationships. It's recognizing that you need to pull your partner into care. You're not alone in it. And if you're wanting to navigate that together, you've got to do it together. If you're trying to make big lifestyle changes, a lot of women gain weight around menopause. You want to quit carbs and you want to do, you were driving this car. This is a really good analogy. Pre-menopause, you're driving a car, you go to the gas station, you put the fuel in it, the car runs great, you're doing good. You go through menopause, someone gives you a different car, but it's not an upgrade. And the fuel that you were putting in it no longer works. So women find themselves having to change lifestyle things, the way they eat, the way they sleep, exercise. Their partners need to support these changes. And for a lot of men, that represents changes in a lifestyle that they weren't quite ready or willing to, and success is better when people do it together and support each other. So I spend a lot of time talking about those things as well, which is just another spoke in the wheel, right? It's just another aspect of care. But that is a huge frustration of women, is feeling alone and poorly understood in a process that they don't even feel like they understand, right? It's a tough one.
It is. So that brings us to the end of our interview. Tracy, thank you so much for sitting down and talking with us and sharing your resources, your information. It's been exceptionally enlightening for myself to learn about HRT, to learn about the work that you've been doing, and I really hope that we will have a chance to talk with you again shortly. Thank you so much for today.
Oh, thank you so much. This was an absolute pleasure. Take care.
Thank you, Dr. Rodgers, for providing us with such great information and insight into women's health. The resources Dr. Rodgers talked about will be with our show notes on our social media and YouTube pages. You can stay up to date with Dr. Rodgers' workshops, events, and information resources through her Facebook group, Dead Lady Balls, all one word, or via Instagram at Dead Lady Balls. Dr. Rodgers will be focusing on growing these communities over the next coming months, so stay tuned. Our next health topic is all about breasts. According to the World Health Organization, in 2020, there were, quote, 2.3 million women diagnosed with breast cancer and 685,000 deaths globally. At the end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer in the past 5 years, making it the world's most prevalent cancer. One way for early detection of breast cancer is through self-examining your breasts. The next audio clip is about how to perform a breast exam with Dr. Laura Kruper at City of Hope National Medical Center.
Hi, I'm Dr. Laura Kruper, one of the breast surgeons at City of Hope. Today I'm going to talk to you about self-breast examination. Around 8 out of 10 women detect breast cancers or breast lumps themselves. Therefore, it's important that every woman understand the basics of a self-breast examination. There are actually 2 components, look and feel. For the first part of the exam, looking, You want to stand or sit in front of a mirror. With your clothes off, you want to look at both breasts to see if there are any differences between the two. Examine the nipples to see if there's any difference between the two. Is one redder than the other? Is one pulling in? Then you want to put your hands on your hips and turn from side to side to see if there are any changes. While standing, you actually want to put your arms forward on your hips because this will bring out lumps that might not appear otherwise. It's important to raise both arms above the head. This will draw out any puckering or dimpling for masses that might be underneath the nipple. If you're standing like this and you have a mass that's kind of in the lower part, you might not see it at all. But when you raise your arms, what happens is that mass kind of stays and then the skin kind of pulls in as you're pulling up. That was the first part of the examination. For the second part, you want to be lying down. You want to put your head on a pillow to prop yourself up and place one arm behind your head. Then with your other hand, you want to use your first 3 fingers. When you use only 1 finger or 2 fingers, you can actually separate the breast tissue and think that you feel something that isn't there. You can do this one of 2 ways. You can either go in a circular motion all the way around the breast, making sure that you overlap every area, or you can go up, down, all the way across. I prefer the circular motion, from the collarbone to the sternum or mid-chest, below the breast, and then all the way actually out into the underarm. Lymph nodes are underneath the underarm, and sometimes those can become bigger. When you're doing the breast examination, you're looking for things that feel different from the surrounding tissue. What you're looking for is something that stands out, something that feels like a pea or a marble or a walnut. You want to make sure that you do this examination at the same time each month. Remember, the most important thing about a breast self-examination is to know your breast. That way you can note any changes and alert your doctor.
Welcome back to A Sound Constitution on CHLY 101.7 FM. We just listened to Dr. Laura Kruper walk us through how to conduct a breast self-examination. To move on with our topic of breast health, I will pass the mic over to my co-host Amanda to discuss bra health and hygiene.
Thanks, Cameron. Today I want to talk about bras. Yes, you heard me correctly. I'm here to talk about bras. I can't tell you what percentage of people are currently wearing the wrong size bra, but as a fellow person who wears a bra herself, I know that people experience anxiety about their breasts and have known the discomfort of having a bra dig into their body. This is an important discussion to have because wearing a bra that doesn't fit can actually impact your physical and mental health. Wearing the wrong size bra means that your breasts are not receiving the support that they need for daily activity. And when your breasts do not have the proper support, it can lead to the development of pain and prevent you from engaging in physical activity. One study published in 2010 by the Journal of Science in Medicine and Sport reported that ill-fitting bras can contribute to many negative health outcomes, including upper limb neural symptoms, deep bra furrows caused by excessive strap pressure, neck and back pain, poor posture, and exercise-induced breast discomfort. These symptoms can lead to the avoidance of physical activity and can contribute to individuals having negative perceptions about their bodies. This report also noted that correctly fitted supportive bras have been found to alleviate up to 85% of these symptoms, allowing women to exercise with greater comfort and possibly removing the need for breast reduction surgery. So who can you talk to about finding the proper fitting bra? Health professionals are actually well positioned to discuss bra fitting as they frequently treat people with symptoms associated with ill-fitting bras. Alternatively, professional bra fitters are also well positioned to help you find a bra that will fit for you. A professional bra fitter is trained by bra manufacturing companies to make sure customers are being assessed for the right fit. However, this isn't always an option for people. If you are not able to get professional help finding a bra that's right for you, don't worry because I'm here to discuss how you can correctly find the right bra fit for you. The first thing you need to know is that bras are commonly designed in one of 2 ways. They are either designed as a compression-style bra or an encapsulation-style bra. Both these designs can be worn while engaging in physical activity, however, they do differ in function. Compression-style bras are designed to compress breasts against the chest wall and limit breast motion. whereas encapsulation-style bras include several different components that are pieced together to form a bra that supports each breast individually in separate structures. For a bra to fit correctly, you need to know your correct bra cup size to support the volume of breast that is being contained. You need your bra band to fit around your chest, and you need your bra straps to comfortably rest on your shoulders. The first measurement you need to take is related to your bra band. You need a measuring tape that will fit around your body, and it helps to have someone that you feel safe with to help you take measurements for bra fitting. You will be taking two measurements, the underbust chest circumference, which is the area immediately below your breast, and the overbust circumference, which is the widest area of your breast where your cleavage begins. These measurements need to be taken at the end of normal exhalation and while standing upright. When taking underbust chest circumference measurements, you will place the measuring tape tightly but comfortably underneath your breasts and wrap the measuring tape around your back to the other side of your bust. Make sure that your measuring tape is at the same height across your bust and your back. Once you've placed your measuring tape, write down the measurements for your underbust. This will be the measurement used to determine your bra band size. Now you will place the measuring tape over your bust. This measure must be taken on the widest part of your bust with a fairly loose measuring tape in order to not deform or squeeze the breast. Once again, you have to make sure that your measuring tape is at the same height around your bust and your back. Now you are ready to write down the measurements for your overbust area. Once you have both your underbust and overbust bra measurements, you can determine cup size by subtracting the underbust measurement from your overbust measurement. That number will tell you what your cup size is. So how do you know you have the perfect bra fit? Well, when a bra fits well, they're comfortable and they don't pinch you. Your bra should feel weightless on your body, and the underbust is part of the bra that is giving your breast support. You want it to rest firmly and evenly across your underbust area. When buying a new bra, it can be helpful to fasten your band on the first outermost row of hooks. This will allow the bra to be tightened as your underbust band starts to get slightly looser after you've worn it a few times. If the band rides up the back, it is probably too big. This means that you should choose a smaller bust size and go up a cup size. Your bra straps should sit parallel to each other or in a slight V shape on your back. If your straps are digging into your shoulders, it might be a sign that your underbust band is too big or not giving you enough support, so you should consider trying a smaller underbust size and cup size. If the straps, after being adjusted, are slipping down your shoulders, it means that the underbust band is too small and you need a different underbust size and cup size. The cups of a bra, especially when underwired, should go right under the contour of the breast, sitting flat against your ribs without digging into the breast tissue. The whole breast should fit neatly into the cup with no excessive flesh showing on the side or spilling out over top. This applies even when wearing push-up bras or low-cut bras. There should not be any space underneath the cups at the root of the breast or any gaping across the top half of the cup. Before you change the cup size, please make sure your breasts are completely dropped into the cups. You can do this by leaning in a bit forward, lift your breasts and jiggle them into the cup and smooth out the sides. If you feel the underwire is digging between your breasts or in the breast tissue, try going up one cup size bigger, but keep the underbust the same size. If your underbust band is curling up or standing away from the body, the cup is probably too small, so you should go up one cup size, but keep the underbust the same size. If the cup puckers and looks a little bit baggy, it's probably too big, so you should try a smaller cup size in this case with the same band size. The center front of the bra sits between the breasts and is also called a bra bridge. The bra bridge should lie flat against your body. If there is a gap between the bra bridge and your rib cage, or the bra bridge sits on top of your breast, it might mean that your cup size is too small. In this case, you should try to go up a cup size, keeping the underbust the same size. And now, ladies, gentlemen, and non-binary friends, you now know how to properly fit a bra to your body.
Thank you, Amanda, for teaching us about bra health and hygiene. This episode has been full of information about women's reproductive and sexual health, and we could honestly talk about this topic for hours. However, this is all the time we have for today. So, if you would like to learn more, head to our show notes for some resources. A big thank you to Dr. Tracy Rodgers for sitting down with A Sound Constitution to give some insight about women's health and menopause. And thank you to Dana for conducting this interview. Thank you to my co-hosts for sharing information about women's sexual and reproductive health. And lastly, thank you to our listeners for joining me today to talk about a subject I care very deeply about. While it was a lot to cover in a short amount of time, I hope it's created a spark of interest about women's sexual and reproductive health and provided you with some new information and learning. For details and show notes from today's episode, or to follow along on what's coming up this season, check out our Facebook page, A Sound Constitution, and our Instagram at CHLY A Sound Constitution. If you've missed parts of this episode or would like to listen to this episode or episodes from our past shows, check out our YouTube at A Sound Constitution. We'll see you next time.